Welcome, and thank you for joining us for our webinar, Beyond COVID, the broader reach of bioethics research from the pandemic. I'm Misty Alt-Anderson, Program Director here at the Greenwall Foundation, and I'm filling in today as moderator for Michelle Groman, who was unable to join us. The Greenwall Foundation seeks to make bioethics integral to decisions in healthcare, policy, and research. One way that we do this is through our Making a Difference program, which is now in its 10th year. This program funds research that aims to have a real-world, practical impact on important unanswered bioethics problems in clinical, biomedical, and public health decision-making, policy, and practice. We currently have an open RFP for the Making a Difference program, and letters of intent are due on June 26th. You can find that RFP and additional information on our website, greenwall.org. 3 of our grantees from the Making a Difference program are with us for today's discussion. While their projects are quite different in focus, each one took up a pressing bioethics question during the pandemic. Although COVID-19 is not fully behind us, the recent end of the public health emergency gives us a chance to take a look back at the challenges the pandemic brought. And we ask, what have we learned from the pandemic era research? We'll start with a short presentation from each grantee about their projects, and then I'll lead a roundtable discussion among the group. After that, we'll be able to take some questions from the audience. You can submit questions at any time using the Q&A function. This webinar is being recorded, and we will upload the video to YouTube and make it available on our website after we're done. Our first speaker today is Dr. Brendan Saloner of Johns Hopkins University. He led the project that was entitled Rationing Behind Bars, Resource Allocation in Jails and Prisons During COVID-19. Brendan, over to you.
Thank you, Misty. All right, let me just share my screen to slideshow view. All right, great. Well, I'm going to try to be quite quick here and just tell you a little bit about our project. So first of all, a big thanks to the Foundation for the Making a Difference grant, and the disclaimer that all the views here are those of our team and not the funder. And of course, a big thanks to the participants in the study and to my colleagues on the study team. So I think it's been well documented and is well known by now, the COVID pandemic was an unprecedented risk to the health and safety of incarcerated people. We know that going into the pandemic, jails and prisons were often overcrowded and under-resourced. So many people, including myself, sounded the alarm bell at the start of the pandemic that this was going to be very calamitous in jails and prisons. And indeed, what we saw is that there was massive propagation of COVID in jails and prisons all throughout the pandemic. Shown here are a couple of figures from a study that I was involved in looking at prisons in the US and the excess rate of COVID cases and deaths compared to the general population. So with this in mind, we launched our Making a Difference grant to look at some of the tough decisions that were made with limited resources in carceral facilities. And we had 2 empirical aims, one focused on decision makers, in this case, medical and security leaders, to understand how they approached their tough decisions and how they thought about some of the difficult trade-offs, the extent to which they thought about ethics questions. And then we also wanted to talk to people who were on the receiving end of those decisions. So people who were incarcerated during the pandemic, how did they perceive the fairness and legitimacy of decisions made on their behalf? How did those decisions affect their health and well-being? And so we interviewed 21 people who had been released from the Federal Bureau of Prisons. And then a more explicitly normative aim to develop a framework in which we would look at some of the justice and human rights considerations and develop a framework to think about how to approach the health and well-being of incarcerated people during pandemics. So I'm just going to review some of the themes from the study very quickly. Early in the pandemic, we know that leaders made some very sweeping decisions. They had to make decisions that restricted the movement of people in facilities, cutting off social activities, canceling visitation. They were working with limited resources. I think one of the key resources, which we hadn't realized just how acutely limited it would be, was actual staff time, which was, compounded by the fact that many staff were out sick during peak periods of spread, a lack of testing supplies at times and masks, and the realization that some of these decisions were being made just on the fly, as this one respondent told us, really without any kind of national guidelines, CDC guidelines did ultimately come through. They were not very specific, and in some cases came well after many of the most difficult decisions had to were made in these facilities. So when we talk to leaders about their decisions, they tended to think that they had made successful choices, but they really were trying to get back to what they thought of as the pre-pandemic normal. And we talked to them more than a year into the pandemic. So this person, for example, working in a youth facility said, I actually now feel that the youth are safer with us, because what I'm seeing is that they go back into the community and they're not social distancing, they're not masking, they're not necessarily getting the medical care that they need. So this person sort of saying that actually it's better, all things considered, that the youth are in the facility than out in the community from a safety perspective. This leader was talking about the fact that, they had put all their energy toward COVID, and they really were unable to meet some of their basic programmatic needs, doing routine medical care and whatnot, and trying to deal with that backlog. By contrast, when we talk to people who were incarcerated, they very much emphasize the aspects of their experience that were harmful and punitive. So they talked a lot about experiencing lockdown. Lockdown is a term that often has a very punitive meaning, or a meaning related to sort of addressing a security risk, but the same kinds of techniques and strategies that were used to contain a security risk in a facility were also used in the name of containing COVID. So this person said, while we was on lockdown, we shouldn't have been treated like we had done something wrong. Shouldn't have been to the point where we were being fed peanut butter sandwiches for 3 months, or if you had a problem, no one would come and talk to you. We heard some really devastating stories. This person talks about one toilet between 26 people, one shower, just not getting phone calls, not receiving medical. Again, a lot of people talking about just like the fact that they couldn't have hot meals for weeks on end and how difficult that was. And at baseline, trust was not high between staff and incarcerated people, but a lot of what was reported was an erosion of what trust, existed. So people felt like there was little communication about what was being done and why those steps were being taken. And that led to incarcerated people not feeling like they could be honest. Why would I tell the administration I'm sick when the only thing they're going to do is to take all my property, separate me from all my property, stick me somewhere in some type of quarantine, but I'm not going to get any type of treatment. So it discouraged people from telling, because they know, okay, I could tell them and I'm not going to get any treatment. I'm going to get separated from my property and get quarantined. At the same time, I'm going to put the whole institution back on lockdown. And then kind of a similar comment about someone not wanting to get tested, because again, feeling like getting tested would just lead to a bad outcome for them and nothing really good would come from showing up positive. I'm gonna, just to the gist of this quote is someone saying that, they didn't feel like there was a kind of reciprocal level of precaution from the staff, that they were often doing their jobs without, taking basic safety measures. And it felt like, at the end of the day, when there were bad things that happened, it fell very much on the incarcerated people. And this also kind of spilled into how incarcerated people felt about vaccination. I think it's been well reported that vaccination rates were quite poor in carceral facilities, even after they became widely available. And a lot of that came from people telling us that they just didn't trust the information that they got from the staff. And in fact, some of them said, I did get a shot after I was released, but I didn't want to get it while I was incarcerated because I just didn't trust the information from the staff. And this person says, no one in the institution trusted the vaccine. The majority of the staff were like, no, I don't want to be vaccinated because this came out so fast. We don't know what's going on with it. One of the reasons I declined it is because the medical staff seemed like they didn't trust it. They might not say nothing, and some of them still got the jab, but the way they were looking at it, the way they were moving, it wasn't encouraging. It didn't motivate me to be like, okay, they trust it, let me do it. I guess if you are looking for a silver lining, some of the people in our study benefited from expedited release procedures in the Federal Bureau of Prisons, which for many of them was very stressful at the time, but ultimately led to a successful story of reentry. So for example, on the stressful side, this person said, I came home with no address. I was homeless, which I shouldn't have been because I had a home. It's just that they dragged their feet and I didn't get the paperwork done. When they released me from there, I was like, wow, they just released me to nowhere. I was homeless and I just had to do all this myself. I had to get my ID. I had to get Social Security. I had to get my birth certificate because how am I going to get a job without all that? Usually pre-release of the facility would have all that set up for you and you would attend a pre-release class. On a more hopeful note, we have someone like this respondent said, I've been very kind and gentle with myself and I ask questions and I try to ask questions when I get frustrated. And this person is saying, like, you know, when they hear complaints, they say that's the least of my worries. Somebody's worst day is still my best day. So I'm now going to just seg to talking about some big takeaways. So jails and prisons for sure modeled through the first year of COVID, often without clear guidelines. Many people, I think, doing heroic work inside, but not really doing it in a way that was consistent or always sort of met best public health practice. Pre-existing COVID, there's been a pervasive culture of secrecy and isolation. And I think this really prevented collaboration and communication about what was happening across facilities and with public health. And I think that, you know, a lot of the falling down of what happened was a lack of clear command and control and resource allocation guidelines. So we need to invest more in that. Another big takeaway is just creating conditions for successful reentry. We know that the carceral populations went down dramatically, but that it was still a positive experience for people who were let out without a safety net. And if we are really interested in reducing recidivism, investing in carceral healthcare and transitions can advance this goal. I do have some broader reflections on this project, but I'm going to just hold them because I think I'm out of time. So with that, I will end and say thank you. These are some of the publications that came out of this study. Thank you.
Great. Thank you so much, Brendan. Next up is Jason Schwartz of Yale University. His project was entitled Evidence and Uncertainty in COVID-19 Vaccination Policymaking. Jason, the floor is yours.
Misty, thanks very much. And thanks to the Greenwall Foundation for supporting our work on COVID vaccine policymaking. This is work jointly with Jonathan Moreno from the University of Pennsylvania and Angela Shen from the Children's Hospital of Philadelphia. So if we go back to the summer and fall of 2020, when the vaccine programs were in development during those worst initial months of COVID, there was a great deal of enthusiasm around the role that vaccines could play. And in the bioethics world, there was a great deal of really important work happening regarding those questions about how to prioritize or allocate those initial doses of the vaccine or vaccines if they should prove to be successful. Important work, classic bioethics issues and resource allocation, and really valuable in helping thinking about those issues that would mark the start of the vaccination program. But my own work in vaccination policy that I'd been thinking about for some time reminded me that there would be other ethical issues, and plenty of them, after that initial period where scarcity would be the principal constraint for the vaccination rollout. Issues around how to think and talk about the risks and benefits of vaccines, how to evaluate safety considerations, how to talk about communication and public trust, how to use vaccines in different groups, particularly children, all sort of, interesting issues that are scientific and technical in nature, but also raise questions of ethics and values and the role that government and public health can play in shaping the medical and public health environment around vaccines. I also knew from my prior work in and around vaccination that one principal site where a lot of these questions would be debated would be the advisory committees that support the work of the Food and Drug Administration and the Centers for Disease Control and Prevention. These advisory committees are longstanding support structures to help evaluate evidence, to make some of these difficult, challenging judgments, deliberating publicly, open to public gaze, filled with experts from academia and medicine and research. And that understanding how these groups could contribute to the vaccination rollout could help us think about the ways that ethical issues would inform the vaccination program, not just in those initial days and months, but in these years as we find ourselves sitting here 3 years later. So the goal of our project was to understand the ways that ethical considerations inform that scientific and technical work of shaping the COVID-19 vaccination program and how it evolved over time, and the degree to which those ethical considerations were either explicit or implicit in some of the work, particularly of these expert advisors at FDA and CDC. So we wanted to study those processes, and we wanted to develop recommendations, frameworks for thinking about how the often latent ethical considerations that we had seen from our prior work maybe could be brought to the surface to help shape and inform these really difficult, vexing questions that public health officials and the advisors who support them have to confront. So that's what we did through this project. We very carefully studied the materials, the meetings, the documents, the presentations, the proceedings of those principal FDA and CDC vaccine advisory committees from 2020 up to the present day. And in fact, as we sit here today, the FDA vaccine advisors are meeting to discuss what's going to be in the COVID vaccine that will be recommended to receive this fall. So the work continues, as I'll say a little bit more about in a minute. So we wanted to really try to understand those deliberations and the role that ethical considerations played in concert with the scientific and clinical and technical work. And also, we wanted to do so through documents, through meeting transcripts, through presentations, and from talking with some of the key stakeholders, the key informants, the key participants in these activities to try and understand these questions, these processes. So that's how the project unfolded over these past few years. In terms of what we found, the project gave us a rich set of material to explore, probably far more than what we could have anticipated when we were crafting this project again, prior to the introduction of the first COVID vaccines. There were some issues that have emerged over the past few years that we anticipated, issues around the vaccine safety signals and public communication when those signals emerge and how they're studied and evaluated. For sure, issues around the international environment in which the COVID vaccine program would play out, and the ways in which U.S. regulators have to be attuned to and thinking about the international implications of their decision. But there were other issues that we certainly didn't anticipate that has given us plenty to think about and reflect on over the course of our project. One, maybe foremost, has been this marked turn towards the politicization of attitudes regarding vaccination programs to a degree that we hadn't seen in the past, and the ways in which that has implications not just for how COVID vaccines have been talked about and discussed and promoted, but potential spillover effects for vaccination and other public health campaigns going forward. Gave us plenty to think about as we tried to understand how these expert processes either contributed to or responded to this environment that COVID vaccines found themselves in. Another issue that we didn't anticipate, crafting this proposal, but has been, particularly ripe for understanding the questions at the core of our project, has been the issues around waning vaccine protection, the emerging need and evolution of booster vaccine doses, and all of the twists and turns that the vaccination program encountered over these past few years. Again, a story that continues even as we speak, thinking about questions of science, priorities, investments, risks, and uncertainty, and issues where experts have to make decisions often in the face of sometimes limited, sometimes ambiguous evidence to think about how to best promote public health, how to balance what we know and what we don't know. So these have been, really interesting ways to try and get at some of the questions at the core of the project. As it reaches its conclusion, just a few of sort of the principal findings I want to share with you has been the reminder. Perhaps it should have been more obvious from the start, though, the reminder of just how challenging it is to undertake this expert scientific, medical, and in fact ethical deliberation under exacting public scrutiny, as these FDA and CDC expert advisors have had to do, and the challenges that come from trying to promote the environment of transparency and open deliberation that has been a hallmark of these processes and has been seen as an asset to their work for decades, with the concern that these sometimes unwieldy scientific debates can promote the kind of confusion or public uncertainty or declines in public confidence that they're actually intended to mitigate. So my colleagues and I have written some pieces thinking about ways to coordinate and streamline and try to strengthen this advisory process to try and address some of these concerns. Two other areas, of course, this question that we've seen not just for COVID vaccines, but throughout the public health response to COVID and how folks think about lessons learned from it, are these issues of communicating uncertainty, the need for changing recommendations in the face of changing evidence, and the ways in which that topic plays out in how public understanding and public support for public health measures and the institutions that support them contribute to it. So we've looked carefully at some of those issues and the ways in which these expert processes can support that effort. And lastly, given that these are really interesting public forums and this idea that the idea of public access and open participation and a chance for the public to contribute to these expert processes has long been seen as a real point of value to the FDA and CDC advisory groups that we've talked about. I've spent time thinking a lot about the role of the open public comment periods, which have very often during the COVID vaccine story become forums for unfounded hypotheses, misinformation, unconfirmed allegations to find a loud audience, a loud megaphone in terms of amplifying information that isn't supported about the safety and necessity of the vaccines. So just to wrap up in terms of thinking about impact and next steps, as this project was clearly rapidly unfolding, we recognize that contributing to the public conversation beyond the pace of academic publications was warranted. So my colleagues and I have contributed pieces in forums such as the Health Affairs Forefront and the Hastings Center report website that give us the ability to quickly join the public conversation around vaccine policy and vaccine policy making, bringing some of our insights and perspectives from this work to broader audience, as have opportunities to contribute to media conversations, trying to understand what's been happening with all these twists and turns of the vaccination rollout. So those have been really important ways to contribute publicly, as well as roles for ourselves to advise institutions of which we're part of, schools and universities, and to consult with policymakers. Going forward, while these issues have been very unique to the public health emergency, unique to COVID vaccines, by no means do these core questions about the ethical work of expert advisors find themselves limited to COVID vaccines or even vaccines generally. As we move forward, there's lots of questions about what future iterations of COVID vaccination will look like, particularly as we move to a different model where questions of cost and access and value will have to be weighed and prioritized. Again, technical issues, epidemiological issues, but ethical issues as well. Broader questions for vaccines when we think about safety and public trust and public communication, as well as for pharmaceuticals more generally. These expert processes are doing rich and important work, making judgments that shape the kinds of medical products that are recommended, endorsed, available for us, not just in pandemics, but otherwise. And our hope is that some of the insights from this work in this unique period in time will help us to continue to contribute to strengthening those processes, strengthening the work that these expert advisors do, and bringing greater attention to the ethics and values that also shape the scientific and clinical work they do. So with that, again, my gratitude to the Greenwall Foundation for supporting our work, and I will throw it back to Misty.
Oh, thanks so much, Jason. Our final presenter today is Professor Seema Shah of Northwestern University. She led the project entitled Ethics in the Interim, Learning from the COVID-19 Pandemic to Develop Ethical Guidance for Data and Safety Monitoring Committees Overseeing Clinical Trials. The floor is yours, Seema.
Thanks so much, Misty. So I'm delighted to be here, and I'm going to pick up on the theme of casting a spotlight on topics we didn't think a lot about before the COVID pandemic, and these expert bodies that are sort of functioning behind the scenes that Jason was just talking about, but I'll be talking about data monitoring committees. So data monitoring committees, in case you're not familiar with them, they include statisticians, clinicians, and sometimes ethicists to oversee ongoing trials and look at unblinded data. And they've been called sort of the secretive group at the center of the largest vaccine trials because not a lot is really known about them. Sometimes people call them data and safety monitoring boards as well. These committees or boards make recommendations to either stop, modify, or continue clinical trials as they're ongoing. And these can be really complicated. So as more adaptive designs are being used, where depending on what the data is showing, an entire arm might be dropped from a trial or a new intervention might be added, data monitoring committees are increasingly important. And the COVID pandemic really highlighted why these committees are so important. The COVID Vaccine Data and Safety Monitoring Board published an article describing their operations and the tremendous amount of work that they did in the COVID pandemic to look at really a platform of vaccine trials. Larry Corey said, "Never have so many of us in investigative medicine owed so much to so few." And I really think this extends to the general public, this quote from Winston Churchill being paraphrased for this purpose. So we realized that during the COVID pandemic, there were many research ethics challenges related to COVID-19, where data monitoring committees were uniquely well placed to jump in and address those challenges. So these are just a few of the articles that were published talking about how the volume and pace of clinical trials really required effective oversight by data monitoring committees. Another issue came up with respect to treatment trials, especially those where there were some adaptive approaches being used, like the recovery trial in the UK, which famously really gave us some of the best evidence we have about treatments for COVID. And finally, we wrote an article about one ethical controversy you may remember about whether placebo-controlled trials were still ethical after vaccines were approved. And we thought the data monitoring committees really had an important role to play there. But we realize there's also limited ethics guidance for data monitoring committees. There are a bunch of case studies and textbooks, but they're mostly written by statisticians and clinicians. And DMCs have these bespoke ethics guidance, really. So they have statistical analysis plans and stopping boundaries that help guide their decision making. And they also, I think, historically have had many very experienced DMC members who can exercise their judgment. But there's limited explicit guidance on DMC ethics. And as the need for DMCs increase, the supply of experienced members can't keep up with that demand. So we assembled a team across the world to look into this issue. We had a site in Kenya that was led by Dorcas Kamuya, and we also worked with Alex Hinga there. Several of the people who are working on this at Lurie Children's are in the center, and then Lisa Eckstein, Jonathan Kimmelman, and Annetta Ridd were also part of the team. And we had 3 aims. I won't have time to tell you about all the work we've been doing, but I'll just note we first wanted to comprehensively identify the existing guidance, then identify and target key ethical challenges that require further guidance, and then address those gaps by developing decision-making tools. So our methods, I'll tell you very briefly. We use semi-structured interview guides, interviewed over Zoom and Microsoft Teams, recorded and transcribed our interviews, and conducted thematic analysis. We had 22 respondents, 4 of whom were ethicists, 6 statisticians, 8 clinicians, and then people with training in multiple areas. I will briefly present 4 themes for you that I think are some of the most interesting and some of the ones that I'm still trying to figure out exactly how we move forward from these. First, related to the experience and qualifications of DMCs, their relationships with institutional review boards, their ethical duties, and moral distress. So first, their experience and qualifications. Most people described joining a DMC because they were recruited from somebody they knew in a professional context. And there was this perception of a closed club, that you either get invited to the club to join or you don't, but you can't really expressly apply. One person described an application process for one DMC, but that was it. There was also the importance of diverse representation in global trials in particular that was widely recognized, but people noted it was impossible to represent people from all countries in large trials, and also the voices of local members weren't always heard. The second theme was about the relationships between institutional review boards or research ethics committees and DMCs. And here we found views that really populated a spectrum. So some people thought there should be almost no relationship between DMCs and IRBs. Everything should just go through the sponsor or the principal investigator. Some people thought there should be an open channel to talk only when needed, and it should be used in limited ways. And others felt there should be lots of interaction, as much as each of the entities desired. The third theme that we found was that there were varied ethical duties, and it was surprising how many different duties people mentioned. So we found 14 different duties that were mentioned. Some of these were endorsed by almost everyone, like the first about overseeing safety. But some of them were mentioned by only one or two members, like determining if placebo controls were ethical or when participants should be unblinded. And this suggested to us that there's really something very interesting here that I'll come back to in just a moment. One of the ethical duties people talked about was the need to balance the interests of participants versus the interests of society. And I really appreciated this quote, so I wanted to share it. This person said, "You're always making these balances. And so in the end, you start asking yourself, but is it really worth it? I know we are getting more information. I know many more people are going to benefit from this. I feel that already, coming from a low and middle income country, the participants don't have medical insurance. So their choices are much more limited, making them more vulnerable. And sometimes I ask myself, haven't they been burdened enough? And on top of it, we're coming to add the study onto their plate, and it's usually not for their own benefit. It's usually for the benefit of everybody. Must we have an answer to this question? What difference would it make in the long run anyway?" The fourth theme was a theme of moral distress. So many participants had conflicted feelings at various points about whether a trial should continue. And this didn't happen frequently, but when it happened, it was very severe. Some people described decisions being made by consensus and others by voting, and they talked about the importance of a good chair to discuss and guide decision making. However, the types of feelings they expressed were pretty strong and surprising. So one person said, "We've had decisions that were tough, where I lost a lot of sleep. There was at least one occasion where I remember I felt the decision was absolutely clear that we should stop, and the rest of the DSMB wanted to continue. I literally lost sleep over it because I felt bad for the participants. I felt like the question had been answered and it was time to announce the results and let people get the drug, but they opted not to. They did stop it later. That's the problem when you're on a DSMB. What you believe is not necessarily going to carry the day." So looking ahead, I think there's a need to address the perception and potentially the reality that DMCs are insular bodies. This could happen with more recruitment that's wider and more apprenticeships of people so that they can learn how to do this work, or training to expand the pool of people who are ready to do this kind of work. It also seems important for clear guidance about how IRBs and DMCs should interact, given that there's so many different views on this. It seems like this could be a case where high-profile conflict could emerge if people disagreed about how this should happen for a particular trial. And also, a comprehensive list of ethical considerations for DMCs would be really valuable, as I think there was quite a lot of variability. Finally, it's interesting to think about moral distress because this isn't something that's really been reported often in the literature. And it may be that more ethical training and potentially guidance on decision-making processes could help ameliorate this type of moral distress people are experiencing. So I lastly just wanted to acknowledge the Greenwall Foundation for funding this work. I think that they fund a lot of really important ethics work that really does make a difference, but would be hard to fund in any other way. I wanted to thank the stakeholder advisory panel we have, where people have spent a lot of time on DMCs, all the members of our research team, and of course, the unsung heroes, the respondents who have served on data monitoring committees for so long and done so much for all of us. Thank you.
That was wonderful. Thank you, Seema. And thank you all for sharing your projects with us. We'll now turn to a group discussion about what we can learn more broadly from these projects. So if everyone would turn their cameras back on, looks like you have. Thank you so much. And as a reminder for our audience, please submit your questions using the Q&A function below so that we can raise them with the speakers after this portion of the discussion. Okay, so the first question that we'd really love to hear your thoughts on and have this group tackle is a broad one. How did the COVID-19 pandemic affect the bioethics research enterprise broadly? And what takeaways can we carry forward with it as bioethics scholars?
It's hard to answer on behalf of all bioethics, so I'll just take my slice of it. I would say that I'm definitely someone who does ethics work that tries to think about the space of possibility. So I'm very interested in sort of working on making more ethical decisions and working toward more just outcomes, given sort of the constraints that are imposed by different institutions and resources. But I think one thing that the pandemic did in both extremes, good and bad, is push my imagination a little bit more broadly to think about how bad things can be, but also how good things can be. And it made me perhaps a bit more willing to think about solutions that might lie just beyond the plane of what seems currently possible, and to think more about what would be sort of a theory of change that would not take as given some of the things that seem like they are kind of insurmountable constraints. Like the example I gave in my presentation, that 25% of the jail population was decreased over a year. That never existed as even a theoretical possibility for most decarceration advocates. Now it hasn't totally stuck, but I think it's an interesting sort of proof of concept. It happened, the sky didn't fall. What more can we do? So that would be my answer.
I'll add just a thought or two, agree with everything Brendan said. I think COVID, my hope is that it reminded us how we can widen the frame of what counts as a bioethical issue, what's worthy of bioethical inquiry. A lot of bioethics work, as I acknowledged at the start of my remarks, sometimes focuses on a well-defined, robust, important set of issues that have been seen as sort of central to bioethics for a long time. Issues around clinical research, issues around the beginning and end of life, issues around the doctor-patient relationship. And for many years, the question about sort of where issues around public health or our healthcare system or how we think about population health has been a smaller thread in the broader bioethical discourse, with some important notable exceptions and contributions from scholars for many years. But my hope, in the same way that those of us in public health hope that COVID will have cast a gaze on the importance of thinking about public health writ large, I think my hope is that coming out of the COVID pandemic, we recall, and we as a bioethics community think about the breadth of issues as we think about the health of populations here in the United States and around the world, for which there's really important needs and opportunities to continue to cast our focus, just as we do on the healthcare side of things. And I think that's something I hope we take away from in the years to come.
Yeah, just to build on those responses, I think one issue that came up for me personally was just recognizing how much humility I needed to have. And I think one of the things that happened with the COVID pandemic is bioethics became something everybody was interested in. It was implicated in so many of the important decisions that were affecting all of our daily lives. And so then it became hard to say, what are the limits of when I'm going to offer up my expertise? So I think we all kind of maybe learned how to recognize the importance of really understanding the science behind the ethics before we jump in to help. I think the other thing, I had a conversation with Brandon actually a while ago, and he, one of the issues that I saw is that there's so many principles that many of us as bioethicists have been promulgating. And one of the challenges is what happens when you take those principles and you put them into action. And in many cases, I think we saw, for instance, prioritization for vaccines, there was definitely a gap between what the principles were meant to do and what happened in practice. And some of that's, because people gamed the system, but some of that's also because principles there's work in between laying out the principles and applying them. So I think we probably need more implementation science in bioethics. And that was one of the big things that I'm trying to think more carefully about now.
Great, thank you. So the next question that I'd like you all to talk to us about, and this goes back to a little bit that I think was talked about somewhat during the presentations, and it really has to do with the changing levels of trust. So we saw that the pandemic certainly magnified and in some cases accelerated mistrust among the public in some of our institutions and government, public health, and science itself in some cases. So how can bioethics kind of as a field in the work that you all do, how can bioethics help us moving forward and to rebuild this trust? And can it do this work? And if so, how?
So I think trust is both substantively good. It's good in and of itself for people to trust, but it's also sort of like a freestanding principle of bioethics. I tend to think that when other things are done more ethically, trust follows, and trust is good in prison and jail because there's a lot of reasons not to trust. So, but it has to be trust that's well-founded. So I was recently in Switzerland and had a chance to follow the medical staff through a Swiss prison, and I was impressed on how much the incarcerated people there seemed to trust the medical staff, and I think a lot of that came from the independence that the medical staff had and the sense that they were following principles of human rights. So the more that is done to sort of live up to certain values that are recognized as ethical, I think the more that some of that trust in the enterprise will be built back. And I think that, you know, there's a real repair job that needs to be done in many jails and prisons right now around mistrust, because people in our sample said very clearly they didn't trust people to take, take full accounting of their life and really, make decisions that would advance their well-being. And a lot of it came from a sense that those people on the other end were not necessarily representing the values of, concern for their well-being and having a kind of a clear sense of, duties to the patients rather than to something else.
If I might jump in, I think one of the issues that I have been thinking a lot about because of data monitoring committees and how they function is the link between trust and transparency, and that, data monitoring committees are not all that transparent. They have closed sessions. They do a lot of hard deliberations behind the scenes, and then they often, have one line that they report out to the study that say the study may continue as planned. And it's interesting to think about, how the limits of transparency and when transparency is not as good of a thing as it could be. I was really struck by Jason's description of the sort of challenge that people have, expert advisors debating in public some of these hard questions, and whether that might fuel vaccine hesitancy or other concerns that aren't really founded based on the debate. It's just about the need to be able to hash it out and understand what the science is telling us and where to go from there. So I think one issue is we tend to think of trust and transparency as linked, and that more transparency is always good. And I don't know if that's true. I think we should be thinking about what are the messages we send out and how do we share them in an evidence-based way. In terms of rebuilding trust, I think it's a long-term project. And I do think it's what we're seeing in COVID is part of a much larger skepticism. And there's some good from that skepticism that can come if people are able to be educated and learn about the process and engage with it. But I don't know that all of us should be like Aaron Rodgers and doing our own research on vaccines, right? There's some point when you have to sort of let go of a pole vault and leap over the bar. There are things we won't always be able to understand because of how complex they are. So trust is an essential ingredient, but I do think we have to think harder about how we share information to foster trust. And it may not be as straightforward as just being completely open and transparent.
I agree totally with what Seema mentioned about sort of the messiness of thinking about transparency and what a ripe area for sort of further inquiry by bioethicists. With respect to building trust, another word Seema said was the first thing I scribbled down, Misty, when you asked this question about process. I think this is an area where we can think about processes and the ethical importance, foundational importance of building and contributing from bioethics perspective to processes that are seen as fair and inclusive and participatory and consistently applied to help create environments where the outcomes, even if there's not, universal agreement about them, and there almost never will be in health or healthcare or medicine, But from work in public deliberation and deliberative democracy, the idea that if we can build those processes that are well articulated, at least there's the best fighting chance for the ultimate decisions to be seen as reasonable. And I think that's an area where bioethicists and other social scientists can contribute to those conversations as our public health officials undertake this really important, critical work in the years ahead. And there's a lot of work to be done.
Great. I suspect we're going to come back and have some related threads to this part of the conversation when we switch over to the public questions. We do have some questions coming in. So as we get ready to transition to those, I'm just going to jump in here and take a quick moderator's prerogative and ask you one quick programmatic question, and we can kind of move into the meat of the questions coming in. So let me go ahead and ask you guys, why did you seek funding through this particular program? Did you seek funding anywhere else, or did the structure of this program support your work in a particular way that was of interest?
I'm happy to start on this one. This program, like so much of what the Greenwall Foundation does, is unique in lots of ways in terms of putting ethics at the forefront of the kind of questions that are being asked, the kinds of methods and ideas that are being put forward, and sometimes for other funders, government or otherwise, that sort of has to be sort of shoehorned in or scientized into trying and getting at some of these questions that all of us and others that have been supported by Greenwall are passionate about and want to think about. So this program in particular was valuable for its focus, and also the opportunity to within a relatively quick period of time put together a project, go through the funding application process and get to work in ways that sometimes can be more prolonged. And given the urgency of all these questions that we were thinking about around COVID, as you heard here from today, that was a great opportunity to get to work quickly on those questions while the iron was hot. And then lastly, I'll just mention the ability to put together teams. I mentioned my colleagues, Jonathan Moreno, a bioethicist and philosopher, Angela Shen, a longtime FDA and CDC employee and scientist and a public health person. That ability to put together a team to think about these questions, I think, is something the foundation's eager to see, and it was a great opportunity to put our heads together on issues that we all brought different complementary perspectives and interests to our work. So I think all of those things, were what motivated our group to seek out support from the Greenwall Foundation.
I'll just jump in, and I really think it's true that when you're interested in focusing on ethics, this is one of the best places to go. I also really appreciate the Greenwall Foundation's creating a mechanism that's really about making a difference. So I think, in a previous grant I had, it really pushed me to create partnerships that I didn't have before, in order to try and make sure that the work we were doing could actually change things out there in the world. I also think there's something really unique about the ability to think about ethical questions in a cross-cutting way. So, just to pick on the NIH where I used to work, the NIH often is really focused on, you have to think about, the disease area typically, and how the thing you're interested in applies to that area. And if you want to think across areas, it's much more challenging to do. There are a few ways to do it, but not that many. So I think the Greenwall Foundation, with its ability to really zoom out and think about ethics in a way that it affects so many different kinds of diseases and health conditions, that is something really special as well.
Not much more to add, just to say that I think that the project that we ultimately launched was better for the feedback that came from the reviewers that worked with us on it. So that was a unique part of the Making a Difference grant review process that I really appreciated and valued.
Great, thank you for those kind of contextual comments. We certainly appreciate them, as hopefully the audience will as well. And so at this point, we're going to start pulling in some questions that are coming in from the audience. So here is our first question. As funding priorities are changing with the perception that the pandemic is over, if we can kind of put that in air quotes, we're getting there. How can bioethicists continue to focus on vaccine ethics and building trust in vaccines specifically, and perhaps other public health initiatives?
I'll start with A few thoughts. No, it's challenging, and it's been challenging for my colleagues who work on vaccine hesitancy and vaccine policy issues for many years. This is another area where sometimes studying behavioral interventions or the policy making, the effects of particular vaccine policies on vaccination rates or disease rates, sometimes again also sometimes has to be shoehorned into again, not to, by no means do I want to add to piling on the NIH, but sometimes funding priorities that are seen very much in terms of a clinical or biomedical model. So I think, the time will tell. There was so much enthusiasm early in the pandemic that there'd be a sort of a reset in terms of how the research enterprise thinks about prevention writ large, vaccination or otherwise, and prioritizes public health across our government structures. I think, I'm concerned that window has closed, and we won't see those sort of transformations we're thinking about. But there is certain work on the vaccine policy front happening, foundations that support the use of research evidence, foundations that are interested, certainly as we think about the broader conversation of which vaccination falls into around equitable access to healthcare interventions, health equity, and the outcomes that the vaccination programs strove hard during COVID to address, but fell short of. I think, we can think about vaccination as one example of so many of the systemic challenges our healthcare system faces. And I think that might be an opportunity for future work.
I think also the COVID pandemic, with the success of mRNA vaccines in particular, that's a platform that I think will be expanded to many different diseases. And so I think once that happens, that may be something where we'll have to be careful to make sure some of the vaccine hesitancy that accompanied mRNA vaccines for COVID doesn't extend to these new promising approaches. There also is a new RSV vaccine, and the declines in routine vaccination are so stark. So I think part of the problem is that the COVID pandemic and how the issue of trust in vaccines was handled led to many off-target effects that affect other vaccines. So I think in some ways the need to address vaccine hesitancy and trust is even greater now than it was then.
So to even get to a place where we have, and public health initiatives and things like vaccines to bring out to the public, we have, scientific research has to happen first. And one thing that we saw a lot in the pandemic, of course, is this is an acceleration of research, and also a big effort in trying to really connect the public to how scientific research works and how some of these decisions are made. So connecting that to Seema's presentation and decisions that are made kind of mid-trial. We have a question that came in from the audience that talks about how there's been a long established focus on the risk-benefit ratio and making decisions about clinical research and in justifying any individual studies as they move forward. So do you think that following COVID-19 pandemic, the expected societal benefit, right, as a weighing factor, is actually weighted more heavily now in funding and research decisions than it was before the pandemic? And should it be that way moving forward?
It's a really great, sophisticated question. And I don't know if I can do justice to it, but I think one of the really interesting challenges is in our data, we were really honing in on situations where data monitoring committees were seeing that it looked like the treatment was promising. And yet the question of how do you change practice, right, is this question that looms large in the minds of a DMC. And once you stop that trial, that prevents collecting other data, including data on longer term effects. And then once that treatment or vaccine goes out into the world, then if there are longer term harms, those can affect many more people than just those people in the trial. So I do think that one of the key ingredients here is altruism, is making sure that people understand that when they're entering a clinical trial, part of what they're doing is taking on risks for the benefit of others. And that if people endorse that as at least one of their motivations, that can help address this tension of, of using societal benefit to justify keeping people in a trial. There are other mechanisms too scientifically, right? I do think adaptive designs can, or designs that sort of play the winner, can start to create situations where you feed in, you take more people and give them the treatment that is working, if it's working. So there are different ways to address that ethical tension, but I do think it is the fundamental ethical tension that exists in clinical trials, and one that I don't know that we can let go of, but we can think of better ways to manage in the future.
Okay. Brendan, go ahead. I was going to ask if either of you wanted to weigh in on this one as well.
Not on this one, no. I gathered that we had a little time to ask each other questions.
Sure, feel free.
I want to ask my colleagues what the most surprising or unexpected or ethically thought-provoking thing that came out of your study was. What's something that's going to really stick with you?
It's a great question. I would love to hear the same for you, Brendan. I think for me, it was first, it was the two things I highlighted in my presentation, the exclusivity of DMCs. I had never thought about the sort of perception that it's this closed club, and that this way of, you know, reaching out to people because you know them and trust them, that it really does prevent DMCs from recruiting in an equitable manner, and it probably limits the perspectives that are represented on data monitoring committees. And so I think it's just an interesting thing that I had never thought about when I was invited on to serve on DMCs. And the moral distress piece surprised me, because I tend to think of DMCs as having people who are sort of steely, you know, statistically minded, not people who would be perturbed by the data. And so, and the actual work is so abstract that the idea of people losing sleep over it was really surprising to me. And I don't know how often it's a problem, how big of a problem it is, but I really want to dig in further and find out.
I think for me, it was a point we've circled around a few times throughout the hour around this question of the unintended consequences of scientific experts debating hard questions openly, and the concerns among the health officials they're advising that that those hard discussions would be either misunderstood or misinterpreted by the public in ways that could be harmful to the aims of the public health programs they're trying to support. So much so that throughout various phases of the COVID vaccination effort, on several occasions, the FDA and CDC have decided not to convene these expert groups to discuss determinations that for decades would have been things that it would have been unheard of for these groups not to deliberate and make recommendations publicly along the way, in part because of concerns about, you know, further muddling a message in the eyes of the health officials that was already sort of hopelessly complicated. So these are really interesting, big, you know, high stakes questions to think about that sort of upended, you know, decades of sort of, you know, traditional conventional wisdom about the role that these expert processes serve, the value of open public deliberation, and sort of as an unallayed good that I think really has caused me to rethink some of these questions. How about you, Brendan?
I've really thought a lot about what qualitative research can tell us and not tell us about asking tough questions about values. It was incredibly hard in this project to get our respondents to really talk to us about ethics, and usually they resisted the invitation. So kind of how you even get people to think about concepts that are very abstract. And I think that was a finding in and of itself. I think the other interesting thing which really has stuck with me about qualitative research is having two kinds of respondents who went through the same experience in different positions come out of it with totally different understandings of what happened and whether it was done fairly. And what do you do with that? I mean, I think that there's truth somewhere within all of that, but it's very hard as the researcher to sort of sift through it and ultimately say what the truth was with a capital T. So that's something that's really going to stick with me.
Can I ask a quick question of Jason? I know we don't have that much time left, but I was curious about what you were just saying about the issue of how advisory committee deliberations affect public perception. Sometimes I was struck by, with the limited amount I followed what was happening, less so than you, it seemed like there was a lot of speculation about what the public would do. So I was curious if there's sort of a research agenda or, an empirical way or an evidence-based way that we should be thinking about how to understand what the public is likely to react to, instead of just speculating about it and fashioning recommendations based on that speculation.
Oh, such a great question. And the short answer, I'm again mindful of the clock, is no. I think there's been very little empirical work that tries to say, how does the public receive different messages, and how does it add to or contribute to or work against, especially vaccine related hesitancy. But certainly it came up a lot, even in the weeds of certain policy debates among the advisors, of saying, if we do this, if we recommend this vaccine for this group, but not this one, we're going to add to vaccine hesitancy without, sort of the same kinds of data one would expect for some of those, scientific and technical considerations that were before the committee. So it's, I think, an urgent need, frankly, to think about these relationships, because so much of what was being done or not being done had this, there's these potential implications in the background. So no, I'd love to see more work for it. And I think hopefully it does happen.
Great. Thank you all for being so on time and on point with your discussions. And with that, we have reached an hour. And so that will be it for our webinar today. On behalf of the Greenwall Foundation, I'd like to thank all of our presenters for their thoughtful presentations and robust discussion. And thank you to our audience for your participation today. The recording of today's session will be available on our website and on YouTube very soon. And with that, we'll close, and everyone have a wonderful day. Thank you.